All right, good evening, everyone, and thank you for joining us tonight for our Woo You event with Dr. Joe Pizzimenti. He's going to be discussing emerging trends in age-related macular degeneration. So I'll be your host tonight. My name is Dr. Ariel Sorenzi. Well, so I'm really excited to introduce Dr. Pizzimenti. He's going to bring our Retina series on home, and we're super excited to hear from him. So he's a full-time faculty member and tenured professor at the Rosenberg School of Optometry at the University of the Incarnate Word in San Antonio, Texas. He received his OD from Illinois College of Optometry and completed a residency in ocular disease and rehabilitative optometry at the University of Houston. He's a fellow of both the American Academy of Optometry and the Optometric Retina Society, serving as the ORS president from 2012 to 2014. So he's a true expert in posterior segment, and we're so excited to hear from you. So thank you for joining us tonight.
Oh, it's my pleasure. And looking forward to bringing this Retina Rock series to a resounding close tonight.
Grand finale.
Yeah. These are my, go ahead. Yeah.
Oh yeah, so here are his financial disclosures, all of which have been mitigated. So I'll let you take it away from here.
Thank you very much. I have no proprietary interest to declare. And this is Emerging Trends in AMD. I'm Joe Pizzimenti, and really glad to be with you once again here at Woo University. I understand the first two segments of this Retina Rock series were especially interesting, so I will try to hold up the great standard set so far. I would like you to know that I do receive a modest honorarium to edit this monthly e-newsletter that's called AMD Clinical Insights. Now, you can receive this at no charge through Optometric Management, and they'll deliver it to your inbox every month. What we do is once a month, we take some of the latest clinical research in the area of macular degeneration, condense it into maybe a few paragraphs that takes maybe 5 minutes to read, and then highlight maybe 3 or 4 bullet points at the end. And there's usually a case or some interesting images mixed in. So you can sign up through Optometric Management's website for AMD Clinical Insights. I'm also a past president of the Optometric Retina Society. This is our website, optometricretinasociety.org, and we publish a quarterly e-newsletter on all things retina, and it's available to all optometrists and ophthalmologists. You don't have to be a fellow of the ORS, and you can sign up for that e-newsletter either through our website, whose address is right here, or through Review of Optometry online. So that is Optometric Retina Society quarterly retina update. And as our host mentioned, please feel free to type in your question at any time. So our goals over the next 50 minutes or so are to provide clinically useful, clinically relevant information about AMD. And we're going to take a systemic wellness approach to this condition. And that starts with prevention, early diagnosis, leading to early treatment and management. And much of that management centers on nutrition and lifestyle. So here we see an eye with the intermediate form of non-neovascular, also known as dry AMD. We see many drusen on both sides of the optic nerve and throughout the entire macula. This area that I'm outlining right here, this is the clinical macula, right? We're not anatomists, we are clinicians, and this large area within the arcades temporal to the disc is the macula. See here toward the center of the fovea, we've got these large, soft, confluent drusen, which indicate more widespread contamination of Bruch's membrane. The smaller isolated drusen are less damaging than the large, soft, confluent drusen. So this is not early AMDs. This is the intermediate stage of the non-neovascular or dry form of the disease. And so along with viral disease and diabetes and autoimmune disease, unhealthy aging, unhealthy longevity is one of the next great pandemics. An increase in longevity is not necessarily associated with healthy aging, and AMD is part of this. Sick longevity may just be the most serious public health issue of the 21st century. So when we talk about the AMD epidemic, we're talking about the fact that AMD is on the rise. It is the leading cause of blindness in people over the age of 50 in the developed world. On the lower right-hand side, we could see a picture of the neovascular form of the condition, which in this case is bleeding and beginning to scar. So this would be the wet or neovascular form of AMD. So let's get a good clinical definition of what we are dealing with, shall we? So AMD is really a group of disorders, a heterogeneous disorder or a family of disorders that affect the RPE, Bruch's membrane, choriocapillaris complex. Now, early disease is classically characterized by minor vision loss that may be associated with focal or diffuse sub-RPE debris, as well as changes in RPE pigmentation. So a loss of melanin, for instance, is considered to be an early sign of the non-neovascular form of the condition. And then later, advanced disease is characterized by severe vision loss that is associated with extensive RPE atrophy. We call this geographic atrophy, with or without the sequelae of macular neovascularization. So this is our working clinical definition of age-related macular degeneration. And no matter what study you look at, we've got prevalence on the vertical and age on the horizontal, whether it's the Beaver Dam eye study, the Framingham eye study. We can see that once a patient reaches 65 years of age, and then especially at age 75 and older, that prevalence of AMD takes kind of a steep upward turn. So you don't have to be a PhD in epidemiology to realize that the world's population is aging, and that with aging comes an increase in age-related eye disease. And so we are seeing a predictable yet significant increase in AMD patients in our offices. We still classify AMD according to these two subtypes. We've got the non-neovascular disease, also known as dry, or non-exudative, sometimes called atrophic disease as well. And the dry form can be performance degrading, and it represents the majority of AMD cases. What we are looking at, unfortunately for our patient on the upper right, is an area of geographic atrophy, where we have the atrophy of the RPE, the atrophy of even the choriocapillaris, and the overlying photoreceptors. So the photoreceptors, the RPE, and the choriocapillaris all atrophy. In this patient's case, it does involve the foveal center. So just because the eye doesn't have wet AMD, just because it's dry, that does not necessarily mean that it's mild, because many eyes do progress to this end stage of dry AMD known as geographic atrophy. Below that, the neovascular form of the disease, also known as wet AMD, also known as exudative or hemorrhagic. The distinguishing feature for neovascular AMD is the formation of macular neovascularization, that is MNV, which can be devastating to central vision. You could see already here on the lower right, that this neovascular membrane is already beginning to scar, and there is quite a bit of subretinal and probably sub-RPE and even intraretinal fluid going on. Although the neovascular form represents a minority of AMD cases, it is responsible for the majority of vision loss due to AMD. So we talk about the disease, but how does it affect our patients' everyday lives, right? The burden of severe vision loss in AMD affects patients, of course, but also their loved ones, their caregivers, the medical community, optometrists, ophthalmologists. And the consequences of this severe vision loss can be physical. They can be social, with quite a few patients isolating themselves. And we saw this and continue to see this quite a bit during the pandemic. Economic issues, the patient can no longer work, right? Somebody has to take off of work to bring them to their appointment. Psychological issues with many patients that are living with AMD who also suffer from depression. And again, if we're going to stage this eye with AMD that we see, we've got many soft, fluffy, confluent drusen that coalesce together. Once again, this would be the intermediate form of dry AMD right here. These smaller drusen, not as worrisome. And so how should we as optometrists respond to this growing epidemic? Well, ideally, with preventative strategies centered around nutrition and lifestyle that could hopefully deter this disease from even occurring in our patients. But if we can't outright prevent it, let us at least diagnose it earlier in the game so that we can intervene earlier. And that hopefully will result in better visual outcomes and an improved quality of life for our patients. And once again, this large circle here is the macula. The macula is a relatively large region. The fovea, on the other hand, is where I'm outlining now. The fovea is about the same size as an adult optic nerve head. So if we are describing a particular lesion that is within the macula, what we really want to note is how close is that lesion to the center of the fovea. Here is our histology of the macula. You could see that when we get to the foveal center, the inner retinal layers drop out, leaving the photoreceptors exposed. And when the retina, the macula, takes light and turns it into an electrical impulse, that process known as phototransduction, this is a process that is very high in heat, it is very high in energy, it is very high in oxidation. So over the years and over the decades, it could be said that the macula eventually becomes injured by its own activity. So here is an eye with mixed drusen. We have some small, well-circumscribed hard drusen, and we have some of the larger soft drusen. I will tell you that histologically, the difference between a hard druse and a soft druse, the difference is inflammation. And here is what these soft drusen will look like on optical coherence tomography. Again, we've got the vitreous up here, jet black, because it's 99% water. Here we have a separation of the vitreous base. So we have a localized PVD that is still attached, that appears around that optic nerve head. And we've got these RPE elevations, right? And underneath these RPE elevations, we have some heterogeneous material. And when the material looks like this, it tends to be druzenoid material. So we could call these druzenoid RPE detachments because it is the drusen that separate this brightly reflective pigment epithelium from the now visible, very faint Bruch's membrane. And as we look at some of the AMD risk factors, we could see that some of them are not very modifiable, such as age and heredity, but many of the risk factors are not only modifiable, but they are also systemic in nature. And so we've got smoking, which is an indisputable risk factor for AMD, along with age and genetics. So heredity, if the patient has a first-degree relative, a parent, a brother, or a sister that is living with AMD, then they themselves are at a significantly increased risk for developing AMD. We've got cardiovascular disease, blood lipid status, hypertension. So again, many systemic risk factors for AMD, and later on I will make the case that AMD is actually a systemic disease with local manifestations in the human macula. Excess alcohol, light exposure, including ultraviolet light and blue light, not from your cell phone. Nobody gets AMD from their cell phone. The cell phone has the blue light, it's true, but the light is not nearly intense enough to cause retinal damage. What has the right wavelength and the right intensity to damage the retina? It's the sun. Blue light from the sun is a significant risk factor. Poor nutrition, obesity, low macular pigment optical density, and poor dark adaptation. If you question your patient carefully, they may complain about trouble seeing in dim or dark environments. And so, this is a complex disease that is multifactorial. It involves the senescence of the photoreceptors as well as the RPE Bruch's membrane choriocapillaris complex. Bruch's membrane itself becomes less permeable and more thickened and brittle in AMD. As we said, there is a genetic component. Approximately 70% of all cases of AMD do have a genetic component, but as I like to say, DNA does not necessarily equal destiny. Just because a patient has been dealt a poor deck of cards genetically, they can actually change their genetic background by living well. And so, once again, the genetic component is there, but it doesn't sentence that patient to a lifetime of low vision. And then we have environmental stressors. And this comes down to lifestyle and nutrition, right? If somebody is going to smoke cigarettes all of their life, this is going to affect things negatively. Then there is light-initiated oxidative damage. Okay, so phototoxic stress as well. Just a reminder to please go ahead and type your question into the Q&A box. If we don't get to your question tonight, I also want you to have my email address. It is pizzimen@uiwtx.edu. So another emerging trend that we're seeing in the AMD research and the AMD literature is this concept of macular degeneration as a systemic disease. I have for you here on the left the cardiovascular disease triad, with brain and cerebral circulation being affected, heart and coronary circulation, and then peripheral vascular disease of, say, the lower limbs. I am ready to add AMD to this cardiovascular disease triad and make it a quartet because I believe that these drusen are a sign of more widespread metabolic dysfunction throughout the body. And lately, some of the literature is starting to prove that. Here we have a little bit of RPE hyperpigmentation. We've got this small zone. I don't know if you could see that it's a fainter color, but we've got this small zone of geographic atrophy. It's not foveal, but it's close to the fovea. And when geographic atrophy is close to the fovea, it tends to grow quicker than fovea involving geographic atrophy. So the fact that this small area of GA is next to the fovea, this probably means that it will grow rapidly. AMD and drusen, all right? So as I tell my patients, AMD is a disease resulting from poor waste management. You have these cells, they're called RPE. Their job is to take care of the waste products that accumulate within the retina. Unfortunately, your RPE are sick and they're no longer able to do their job efficiently, probably due to oxidative stress, right? And the result are these little pockets of inflammation that are known as drusen. And we didn't know that 30 years ago when I was a student. But we now know through recent investigations that proteins that are associated with inflammation and immune-mediated processes are prevalent in drusen. So AMD is above all else an immune-mediated process. We will talk about the complement system in a little bit, but when you hear complement system, what do you think of? You think of the immune system, you think of an inflammatory cascade. These are all involved in the process of AMD. So drusen, as we see right here, is the earliest clinically detectable feature of AMD. So ophthalmoscopically, the first thing we're going to see are drusen. Is AMD a sick eye in a sick body? Unfortunately, it is way too late for this eye, right? We already see geographic atrophy on both sides of the optic nerve, and the central retina is, of course, affected. What we're looking at on the right here is fundus autofluorescence, a non-invasive imaging method that is going to be very important in imaging eyes with geographic atrophy that is not this severe. So autofluorescence can be generated in the pigment epithelium in one of two ways, either with a special attachment, a filter, greenish blue that's attached to a fundus camera, or with some sort of confocal or scanning laser device, such as an OCT. We could see that these bright areas here, we call these hyperautofluorescence. This indicates that the pigment epithelium is sick and stressed. These dark areas, these black areas, indicates that the pigment epithelium has died. So when we see, for instance, this area of cellular death surrounded by hyperautofluorescence, well, unfortunately for our patient, this area of geographic atrophy is going to continue to march into the more peripheral aspects of the macula. So our goal is to identify these eyes much earlier, before the geographic atrophy becomes this extensive, and to image these eyes with fundus autofluorescence primarily in order to gauge the damage. So is AMD the eyes version of cardiovascular disease? Let's look at these parallel worlds, right? Both heart disease and AMD are exacerbated by a diet that is low in fruit, fresh fruit, and vegetables, right? Patients who are obese and physically inactive are more likely to develop cardiovascular disease, and AMD. Think of how many of your AMD patients also visit an internist or a cardiologist. Virtually all of mine do. If we were to run C-reactive protein, an inflammatory biomarker, on all AMD patients, we will note a very high C-reactive protein, likewise in patients with heart disease. Homocysteine may be elevated in both. What is good for the heart appears to be what is good for the eyes. Omega-3 essential fatty acids may be beneficial and protective of both cardiovascular disease and AMD. High cholesterol, high triglycerides, a risk factor for both. Increased amounts of serum iron may also increase the likelihood of developing AMD and cardiovascular disease. So a lot of common ground between AMD and heart disease. And this slide just illustrates what we just said. Patients with AMD also tend to develop kidney disease, peripheral neuropathy, atherosclerosis, other cardiovascular disease risk factors, coronary heart disease, and there appears to be a connection with stroke and dementia. And so here are the four processes of AMD. I'm kind of dating myself with this slide. I'm only 59 years old, but I saw the show Jersey Boys a few years ago and really enjoyed it. But here are the four processes, right? We have oxidation or oxidative stress building up within the retina. We have the two eyes, I call them, inflammation and ischemia. How do I know there's ischemia? Because I can measure the thickness of the choroid. And when we measure the thickness of the choroid using OCT, in AMD patients, we've got a very thin choroid indicating a hypoperfusion to the choroid and its overlying RPE. So we've got inflammation and ischemia. We've got atrophy and we've got neovascularization. If we understand these four systemic processes, all mediated by the immune system, then we understand AMD. And this is the whole lecture, this slide. But since COPE is involved, I'll go on for another 30 minutes or so. So advanced AMD starts out like this. It doesn't start out with one or two tiny, hard drusen. How do I know? We know that from the age-related eye disease studies, right? Eyes with no AMD or very early one or two small drusen, they had almost a 0% chance of progressing to advanced disease. Remember geographic atrophy or macular neovascularization. Those eyes with a couple of small hard drusen had almost a 0% chance of progressing to advanced disease. When we get to this stage, right, intermediate non-neovascular AMD, these are the eyes that we really need to watch. So putting this patient on a vitamin, yeah, that's probably a good thing. But saying, okay, I'll see you in a year, that is doing that patient a disservice. Because would you let your glaucoma patient go a whole year without seeing you? Of course not. You're seeing that glaucoma patient every 3 or 4 months. This intermediate stage of dry AMD, these patients need to be seen every 3 or 4 months, in addition to the nutritional management. So these soft drusen are large, they are ill-defined, and they are confluent, and they indicate more widespread dysfunction of Bruch's membrane, and they may be a sign of more widespread metabolic disease throughout the body. In the ARED study, this eye was called a category 3 eye. Now you could sit there and measure the drusen with calipers and all that, but what I do is I look at the diameter of, let's say, one of the branches of the central retinal vein. If even one druze is wider than this branch of the central retinal vein, that automatically puts the eye into AREDS category 3. And again, this is still non-neovascular. We don't have any macular neovascularization yet, but look at these focal clumps of pigment. These dark clumps of pigment are a prognostic sign that this eye will most likely develop geographic atrophy. This eye doesn't seem to have it, but this eye will most likely develop geographic atrophy. At first, it will not involve the fovea, but it will grow rather quickly to invade the fovea. Or the eye will be developing a macular neovascular membrane. So we need to see these patients relatively frequently, every 3 months, and dilate their pupils and look at their fundus and perform OCT, not necessarily on every visit, but perform OCT to determine whether the condition is worsening. So I've put together this short list of unfavorable prognostic signs that may lead to macular neovascularization as well as geographic atrophy. So soft, large confluent drusen, we knew that. Something called reticular pseudodruzen, which I will show you in a minute. Focal clumps of pigment, which I just showed you, the focal clumps of hyperpigmentation. What if the patient already has wet AMD or geographic atrophy in the fellow eye? That puts them at a significantly high risk in the better eye. Older age, so 75 and above. And then poor dark adaptation is another one. So reticular pseudodrusen, so these are seen as a reticular pattern of small yellowish white lesions, often in the superior macula, but they could be anywhere. Right? Reticular pseudodrusen are considered to be a high risk sign for progression to advanced AMD. So what we see in this eye are traditional drusens, traditional soft macular drusen here, but then this sort of honeycomb pattern surrounding the drusen, and those are the reticular pseudodrusen. And here's how they look on OCT. Okay, the soft drusen are right here. Okay, the thick arrows are pointing to the soft drusen. Also, look how thin the choroid is. The thickness of the choroid from here to here, here to here. Look how thin the choroid is right here. The choroid should be approximately the same thickness as the retina, just so you know. So the choroid should be about as thick as the sensory retina. This choroid is maybe a third the thickness of the retina. We see this in many eyes with AMD. These smaller lesions, right, they're sort of finger-like projections that invade the external limiting membrane right here, right? They go above the external limiting membrane. Those are the reticular pseudodrusen. Here's another eye with several reticular pseudodrusen. It really shows up very nicely on this inner segment, outer segment junction coronal scan, or en face OCT. And many times your OCT will produce this image automatically. With the click of a mouse, you can click on the en face or C-scan OCTs, and you'll be able to see these little excrescences here. These are the reticular pseudodrusen. As I said, a consistent risk factor for progression to both geographic atrophy as well as macular neovascularization. So here is some evidence-based advice for patients, and this is based on the age-related eye disease studies that established risk factors for advanced AMD. So there was an increased risk for neovascular AMD in smokers and in Caucasians in the ARED studies. Increased risk for central geographic atrophy. That is what C GA stands for, central geographic atrophy. Again, smokers, those with higher body mass index, are at increased risk for geographic atrophy that involves the foveal center. Higher intake of omega-3 long-chain polyunsaturated fatty acids and fish. Higher intake of fish was associated with a decreased likelihood of having neovascular AMD. A higher dietary intake of the dietary xanthophyll carotenoids, lutein and zeaxanthin, is associated with a decreased likelihood of having both neovascular AMD and geographic atrophy. Once again, back to the omega-3 intake, this is associated with a decreased risk of progression from bilateral drusen to central geographic atrophy. So there are some things that we can do to help mitigate the risk of progression to advanced AMD, including neovascularization and geographic atrophy. Another emerging trend is home monitoring of non-neovascular AMD, and trying to catch the time that this eye converts to wet AMD. So the technique is known as preferential hyperacuity perimetry. We learned hyperacuity as vernier acuity in optometry school. It simply refers to the eye's ability to discriminate between an object versus other objects in space. So here's our baseline hyperacuity visual field. The patient tests themselves every day on an instrument that you prescribe and that they lease as if they were leasing a cell phone. They test themselves every day. Artificial intelligence algorithms analyze the results, and the system uses telemedicine to alert both the patient and the doctor when we get a change in the hyperacuity visual field defect that looks like this. So the patient is alerted, the doctor is alerted, and then you get the patient in the office, and if indeed the eye has converted from the non-neovascular to the neovascular form, that is earlier detection. We could get the patient timely treatment at the retinologist's office. Home OCT isn't quite ready yet, but it's getting there. Okay, I predict that we will see home OCT available for patients that already have wet AMD, but can monitor themselves at home for new leaks and new bleeds with this home OCT. As I said, it's investigational now, but I believe that within the next year, home OCT will become a reality. And here is hyperacuity once again, the eye's ability to detect an object versus other objects in space, the misalignment of an object versus other objects in space, I should say. And here's a case that we had years ago. You could tell because the OCT is the earlier generation, but our patient had this change in their hyperacuity visual field. And on OCT, here's our thickness map. We have increased thickness that goes with that field defect. Shoot a line through it, and we've got this disorganization at the level of the outer retina, and we've got intraretinal fluid, most likely coming from a macular neovascular membrane. So OCT and PHP can work synergistically. And this is just some more information on home OCT for monitoring therapy of neovascular AMD between office visits. Unfortunately, we can't see our patients every day, so I believe that home monitoring will continue to expand and be useful. So prevention and treatment of geographic atrophy still largely remains an unmet need. Yes, certain nutritional factors, as we just pointed out a few slides ago, can slow progression to geographic atrophy, maybe even help prevent geographic atrophy. But a very good clinically validated therapy has not yet been brought to market until this month. So this is changing, thanks to innovations such as complement inhibition. And so as we look at the complement cascade, right? So we've got a few different pathways. We've got the classical pathway. We've got the alternative pathway. We've got the lectin pathway that activate the complement system, the complement cascade. And C3, the production of C3 and the activation of complement factor 3, this is where a new drug that has recently been FDA approved, pegcetacoplan, this is where the drug exerts its activity, right here at complement factor 3, okay, preventing the cleavage into 3A and 3B. A little bit further downstream, at the level of C5, an investigational drug called avacincaptad pegol, this is where that drug exerts its activity, right here, preventing cellular lysis, preventing further inflammation. So one therapy that is already approved as of last month, I should say, February, and a new therapy that will most likely become approved in the next several months. Once again, I'd like you to feel free to type in your questions. We could see here OCT angiography, another relatively new technology that has become very important in detection of wet AMD. We've got here an eye that already has wet AMD. Look at all the lipid exudates. And here we have an RPE detachment, a serous, because we've got clear serous fluid underneath the RPE detachment. Here is Brooks membrane, and here is that disorganization at the level of the outer retina that may be responsible for this subretinal fluid, macular neovascularization. Multimodal imaging, multimodality imaging is another emerging trend in AMD. All it means is the ability to take pictures or images of the eye with more than one instrument, or with one instrument that does a combination of things. So here is an eye on OCT where we do have some RPE disturbances, some drusen if you like, right? We've got a thin choroid, as I mentioned earlier, very thin choroid, which is associated with AMD. And we've got some reticular pseudodruzen. We also have dropout of the RPE and collapse of the inner retinal layers because of that RPE dropout. And we see an enhancement of the choroid in these areas where the RPE is either thin or gone. We could combine that with our fundus autofluorescence imaging and get a very good idea of where the trouble spots are on this patient. So, this patient actually has an acuity of 20/25 because he's got some viable retina in here. But these areas of paracentral geographic atrophy, these tend to progress very quickly. So this patient would be a candidate for therapy with the new complement inhibitor. Another eye where we've done simultaneous fundus autofluorescence and OCT. Here is our FAF. Unfortunately, it's already taken the foveal center and then some, but we've got some hyper autofluorescence here where the lesion may expand. And once again, look at that hyperreflectivity here at the level of the choroid in the area of geographic atrophy. Okay. Another emerging trend is OCT angiography, and it basically works on the principle of motion contrast. That is the motion of red blood cells through normal and abnormal blood vessels of the retina and the choroid. So here we have our OCT angiography images at different retinal depths on top with the superficial and deep capillary plexi, the outer retina, and we could see that this neovascular complex has originated within the choriocapillaris. Below that, we've got the structural NFOS images of each of those zones as well. Here is serous angioplex OCTA revealing a neovascular lesion in one of my patients with the wet form of AMD. Here is the neovascular membrane. We can see the blood flow overlay, right? So we've got subretinal hyperreflective material causing a serous detachment of the sensory retina from the pigment epithelium. Here's an 81-year-old patient that we were following with mild of reduced acuity was actually about 20/30, 20/25, because only about half of his macula was affected new choroidal neovascular membrane. And we could see down here on our B scan OCT that there's a high degree of intraretinal fluid and thickening here at the level of the outer retina. We also have a very thin choroid. So hypoperfusion of the choroid. Treatment of neovascular AMD, as we look at yet another example of what we're talking about, right? So this is the natural progression of disease. If left untreated, we will end up with a fibrovascular scar. And this once again illustrates why ocular therapies really didn't work, but systemic therapies do. The first ocular therapy that was tried was thermal laser, which is still till this day FDA approved, right? And it's still occasionally used for these extrafoveal choroidal neovascular membranes that are extremely well defined. Juxtafoveal membranes, yeah, you could treat those too with thermal laser, but why would you when you have anti-VEGF? And it's not a great idea to actually laser the fovea. But thermal laser didn't work real well. It had a high recurrence rate of greater than 50%. Why? Because it's an ocular therapy for a systemic process. Same thing with photodynamic therapy, right? So it's a two-step process, injection with a light activated dye that travels up to the eye, allowing for more selective blood vessel occlusion. But unfortunately, only 25% of eyes with wet AMD met the criteria for treatment with photodynamic therapy. It was a nice concept because there would be less collateral damage, and it's still FDA approved, but seldom used anymore, another ocular therapy for a systemic disease. So then the researchers around the year 2000 began to look at these processes, began to look at inflammation, angiogenesis, and vascular leakage, and VEGF, right? Vascular endothelial growth factor. So when VEGF is upregulated, the result are these interleukins, MCP1s, and a double whammy of increased vascular permeability, we call that edema, and angiogenesis, we call that neovascularization, all as a result of inflammation and ischemia causing the upregulation of vascular endothelial growth factor. So the process of VEGF-A in particular binding to its receptor cell. Once these drugs were brought to market, scenarios like this became less and less frequent. We still see eyes like this on occasion, and it's very sad that they didn't get the treatment. But nowadays, with anti-VEGF therapy, the eyes do much better than they did before. So, two of these therapies are on label, ranibizumab and aflibercept. One of these therapies is off-label but frequently used, bevacizumab. All are relative, but I do want to talk about a recently called faricimab. This is a bispecific body that targets two pathways, VEGF and the angiopoietin pathway, specifically the angiopoietin-2 pathway. So there are two ligands, angiopoietin-1 and angiopoietin-2, and they both affect this Tie2 receptor. And this receptor is critical for the stability of all the vascular tissue. In neovascular AMD, Ang2 is upregulated, and this competes with the Ang1 Tie2 signaling, causing vascular endothelial tight junction breakdown. So now we have breakdown of the blood-retinal barrier, as well as increased inflammation and macular neovascularization. So phase 3 studies called Tenaya and Lucerne evaluated faricimab in neovascular AMD, and both studies achieved visual outcomes with the drug that were non-inferior to those of aflibercept injections every 8 weeks. The drug is also approved for diabetic macular edema and is commercially available as Vabysmo. So this is a highly potent drug that has been recently developed that we can add to our method of treatment for the neovascular form of AMD. So complement inhibition, new therapy for dry AMD, the geographic atrophy form, and faricimab for neovascular AMD. So is there a strategy? Yes, we want to encourage all of these good things, right? Physical activity, more fish, less red meat, more green, smaller portions, nutritional supplements to fill in dietary gaps, and also to help protect the RPE and the photoreceptors. We can indulge in some not so guilty pleasures with nuts that may affect cholesterol levels, dark chocolate, greater than 70% cacao, and red wine, of course, is rich in antioxidants, resveratrol, the molecule in the grape that enhances circulatory health, kind of scrubs the arteries. And I always get the question, which grape, which wine has the best antioxidant activity? Most likely it is Cannonau from Sardinia, which is the equivalent of the Garnacha grape from Spain, but Pinot Noir also. But stick to the red, not so much the white. We want to discourage our patients from a sedentary lifestyle, smoking, drinking in excess, high body mass index. They need to take care of their blood pressure, get their high cholesterol addressed, and we want them to eat more fish and green veggies. So AMD is on the rise. It has systemic comorbidities and implications. Diet, nutrition, and lifestyle all matter. And we have a duty now to take proactive steps, all on behalf of our patients. You can email me your questions at pizzimenti@uiwtx.edu. I also want to put in a plug for an upcoming series here at Wu University that talks in a bit more detail about some of the new and emerging therapies for geographic atrophy in AMD. So look for those talks coming up later on. But thank you for spending your precious time with me.